So just wanted to start out with a slide. This is the hospital I work in, and this is some pictures of my research team, my research mentor, David Ludwig, who I've kind of set out on this journey. And I became interested in low carb not too long ago. I actually started out in the obesity field and doing some research on genetic forms of obesity, then obesity nutrition, low glycemic index, low glycemic load, low carb, ketogenic, and more recently, carnivore diets. And I really have developed a passion for, for research in type 1 diabetes as well, because I think it's a very understudied field, and I'll get into that a bit more. Before I start talking about my and some other research in the field, I wanted to point out, and I think that the discussion just now is a perfect segue into research, right? It's interesting, wherever I go to talk, when I go to a scientific meeting, people will ask me, well, why would you do low carb? It's, it's bad for your cholesterol, it's hard to do, people won't listen to what you say, don't do it, right? When I come to a meeting where people are in favor of low-carb diets, sometimes I get asked, why would you do research? Because research is just so slow and you won't ever be able to move the field forward very much. So between those two standpoints, I'll acknowledge research is a really tough path, especially, sorry, it was too fast, especially when it comes to nutrition research for the points that were stated earlier, right? We can do, there is observational research that we can, on populations, on people that follow a certain approach. But that research is always going to be confounded and biased by other factors that are intrinsic to those people who choose that approach or to those populations who are exposed, right? So it's never going to give us a definite answer to what nutrient or what portion of the diet, or it's not going to be able to answer the question of causality, right? So when you're thinking about causality, like the only acknowledged type of research that there is right now is the randomized control trial that was mentioned. But as stated just 10 minutes ago, randomized controlled trials on diet in humans cannot be conducted satisfactorily because it would have to be a multiple decade trial to assess the endpoints that we're most interested in. Now, that doesn't mean that an RCT couldn't provide important insights on some proxies of long-term endpoints, or that it couldn't, answer specific questions and hypotheses. So in my opinion, we need both, right? We need population science, we need observational studies of individuals who choose a certain approach, we need RCTs, we need interventional studies without control. So we need a whole portfolio of different studies and trials to collect the evidence that we need to answer some of the important questions we have about diet. And I think the other reason why I do think that it's important to take that approach of research is it's not just important to inform personal decisions about foods we eat, it's really important to inform medical guidelines and policies that we have heard many times during these meetings are maybe not as satisfactory as we would hope for. So here goes. I don't think I'll solve the problem, but I see my role in trying to answer some of those questions with the research I do. I'm going to talk today about specifically carbohydrate restriction for type 1 diabetes, which is a topic that's near to my heart. We've heard a lot about carbohydrate restriction for cancer already on the first day of the meeting. We've heard about carbohydrate restriction for obesity. We've heard it's good for blood pressure, type 2 diabetes. I don't think we've heard anything about type 1 diabetes quite yet. And then I'm going to also talk about what I've done on a carnivore diet so far. So just to briefly recap for some of the non-physicians in the room, the problem with diabetes is that we don't either have enough insulin, or we have insulin, but it's not working appropriately or being recognized appropriately to bring glucose into the cells for metabolism and also storage. So this is what insulin does. It opens a channel in the cell, glucose can get into it where it's metabolized. if we don't either have the insulin or it's not acting appropriately, we have glucose stuck in the bloodstream, we will have high blood sugars, and we have like a malnourished situation on the cell. On the other hand, if there's too much insulin around, maybe too much glucose will go into those cells, fat cells and whatnot, and get stored and then not be available in the bloodstream. So that's what I think Gary Taubes alluded to yesterday a little bit. Could obesity be like a problem of fuel storage rather than, or fat metabolism rather than a societal phenomenon? When I think about diabetes, the blood glucose is the most pressing issue. It's what we can measure in the blood. But also, kids with type 1 diabetes, while type 1 diabetes is not caused by obesity, it's caused by insulin deficiency. Those kids are still at higher risk for obesity and metabolic syndrome over time, maybe because they're exposed to higher insulin doses from their diabetes treatment. So what impacts blood glucose the most? Obviously carbohydrates, right? Carbohydrates have the biggest impact on glucose in the blood and also the fastest. Followed by protein, like some protein gets broken down into amino acids, some of which get metabolized through glucose, require insulin for their uptake in the cell. Some other proteins and amino acids are insulin independent, and fats are certainly independent in their uptake. So from that perspective, so how do we treat diabetes? Just as a little background. Everyone needs insulin at all times to provide their cells to shuttle fuels into the cells. So we always have like a basal insulin level present. And then we need a lot more insulin for meals, especially if they're high in carbohydrate, as I just showed. For kids with type 1 diabetes, that is conceptualized by giving them a basal insulin and then giving them meal insulin. With every meal or snack that they eat, they get additional insulin boluses, depending largely on the amount of carbohydrate consumed. Could be done by injection, could be done with an insulin pen, or more recently can be done by insulin pumps. And we've gotten very sophisticated in the diabetes field about giving insulin and changing the insulins to make them faster. And a lot of research in type 1 diabetes expended toward administration of insulin. So how do I get the glucose out of the bloodstream and into the cells? Now, when I think of a homeostatic system, I always think about what comes in and what goes out, right? I can't just think about how to get it out and hope to be successful with that. I also need to think about what goes in. And that is where I think mostly nutrition will come in. And as I'll show you, that has been largely overlooked for kids with type 1 diabetes so far. Why does the current approach... Why does the current approach for kids with diabetes not work so well, right? In spite of all the amazing technologies we have now, like we've come a really long way from not having insulin at all to having insulin and allowing kids to survive for years and decades, and almost as long as if they didn't have the diabetes in some cases. To now being able to measure blood glucose continuously, having insulin pumps that talk with a continuous glucose monitor and give more insulin if the blood sugar is high or rising, cut back the insulin if the blood sugar is low or dropping. So the sophistication in the field has increased tremendously. Nevertheless, the control in kids is far from optimal and actually really hasn't improved at all like we were expecting given the improvements in technology. Why is that? So I'm going to talk mostly about postprandial glycemia because that's the major culprit. In fact, we can control the fasting glycemia very well. After the meals is where it becomes tricky. Why is that? I think in part it's inconsistent meal bolusing. Like people don't always remember to bolus for a meal. People, if they remember to bolus, they may make decisions that they bolus too much or too little. So I think that's one factor. The second factor is we can't actually put the insulin where it needs to be. Like when a healthy person makes insulin, they put the insulin into the portal vein, and so the insulin level at the liver is very high. And so that shuts down the liver from releasing glucose and affects the blood glucose levels in a very powerful way. Then secondarily, the insulin goes to the general circulation, affects muscles, fat, all other tissues, but the levels are much lower in the peripheral circulation compared to the liver. When I give insulin with an injection or a pen, I give that subcutaneously, so the largest level by the time it's absorbed goes in the peripheral circulation and then only secondarily toward the liver. So by default, I need to use more insulin to achieve a similar effect on blood glucose. So I have higher insulin effects on some of my muscle and fat cells and other peripheral tissues, which may contribute to why kids treated with diabetes do tend to have a little bit of a higher body weight than kids without type 1 diabetes. Thirdly, there is a mismatch between glucose appearance and insulin action. So when I eat a meal, especially if it's high in carbohydrate, I will have a peak nutrient absorption after 15 to 30 minutes, whereas if I inject insulin into my subcutaneous tissue, wherever I do that, it takes about an hour before it becomes really effective. So the carbs will always be faster than the insulin and always going to play catch up. Like currently, a strategy that we use for that in the clinic is we try to give the insulin 15, 20, 30 minutes before a meal, but that involves a kid or adult to know what they're going to eat at the meal that's 20 minutes ahead in the future to plan that, know that, inject insulin, then wait and not eat for another 20 minutes. And it's just with time pressures in today's society, not always possible. And then let alone differences in carbohydrate property, right? I came from a field originally where we were studying the glycemic index, which describes how much a certain carbohydrate raises your blood sugar in comparison to a standard carbohydrate of the same amount. So not all carbs are alike, right? So if I eat juice, sugar, tropical fruits, that would change my blood sugar a lot more than the same amount of carbohydrate coming from chickpeas or lentils or other sources. So that's not at all taking into consideration into current. So it doesn't work the way that we hope. And this is like some typical readout from a continuous glucose monitor. A continuous glucose monitor measures your blood sugar every 5 minutes over a 24-hour period. It sends all those readings to either a receiver, like a little device, or even your cell phone, so you can have an app, you can see all your blood sugars like that all the time. You get a tracing, and you always know what your blood sugar is. It's amazing, and these things nowadays can send that data not just to your phone, but also to the insulin pump, as I said, that kind of helps then regulate the insulin to help and control the situation. Brought two tracings, like this is by far the more typical one from my clinics. So kids have, high blood sugars. So this is the target range, like the green zone, and like the target range typically is considered between 70 and 180. I could have a whole different lecture why that is an appropriate target range for a blood sugar, because it's far from a normal blood sugar. But in short, that the target range is set as that because of the large variability in blood glucose levels that we have because of the diet, right? If you had a tighter or a lower target range, like people might overshoot in the low type, like have hypoglycemia and low blood sugars, which would be dangerous. So we set a relatively high target range. But not only is that not a normal blood sugar, but also people spend a significant amount of time above that target range. Now, why is that? Again, it's because of those fluctuations that you have when you're trying to guess your insulin. So some of those high ones, when you go from here and then you shoot up all the way to like 300, 350, that's probably from forgetting to take the insulin before the meal, or that's when, or from miscounting the carbs, or even, giving it too late and not waiting the 15, 20 minutes. So this is a typical day-to-day tracing for a kid with type 1 diabetes. Now the bottom ones, this is excellent. I don't see this very often in my clinic, right? So they have, like, as you can see, most of their blood sugars are in the target range, and then they have these very distinct excursions so that you can kind of already guess when the child is eating their meals, right? So it goes up to 200, 220 maybe. So this is definitely insulin given, but this is the time it takes the insulin to catch up after the meal and bring it back down. So they have these fluctuations. What you see here is where those blood sugars are nearly perfect. Here, like all in target in the early morning hours, that's what you achieve with a closed loop system or with a CGM that talks to the pump, right? So the CGM knows that they're high, it knows they're low. So here it's low, it shut itself off. Here it was high, it probably kicked in some insulin. So after a couple of hours of not eating, you come out with an almost perfect blood sugar level, which is great. However, the second you start eating, it all falls apart, right? And you have the fluctuations again. So that's where nutrition, and as a consequence, this is the state of diabetes control today with all that fancy technology. So this is a hemoglobin A1C graph. As you know, we all like to live in the 4s and maybe 5s. And so the American Diabetes Association and other societies recommend someone with diabetes should be below 7 so that they can avoid most long-term complications. It's a humble goal, right? It's not normal at all, nowhere near, but it's a goal. And this is the hemoglobin A1C on average in the US in children, like across the age range, like children, adolescents, adults. So nowhere close to that target, right? If I look at here the 10, 20, the teenagers, the average is 9.2 for the hemoglobin A1C, putting them at tremendous risk for long-term complications. And then what's going to be even more shocking is if I'm going to tell you that the orange curve is a curve from 20 years ago, and the blue one is the current rates. So not only has this technology not helped us improve diabetes control, it looks like the teenagers and adolescents are actually doing worse. That's an association, right? I don't know why that happened. I don't think it's that they're doing worse because they have better devices. Is it because they have better pumps now that they're doing worse? Is it because they can measure their blood sugar? No, it's not, right? So I speculate that it is because we have all this technology that keeps people in the illusion that now they can be more flexible with their diabetes care and not pay the due attention to nutrition and other factors. This one here also shows, percent time spent in the target range between 70 and 180. And so here, everyone spends at least 20% in that target range, which is not very much, right? We want to accomplish at least 70% according to the American Diabetes Association. With a routine care, and this is a comparison of routine care, and this is a bionic pancreas, which is like the fanciest of insulin pumps that can really kind of take into consideration all data and do almost everything on autopilot. So you can see that this technology improves the time spent in range, but it cannot, no technology gets us beyond this point where like more than 20% of people can spend more than 78% of time in range. So I do think that this is all related to the postprandial ups and downs, right? Like we saw that overnight can be great, but after the meals, we need help. Lastly, I already mentioned that kids with diabetes compared to kids without diabetes in large data sets do have a higher BMI. And sorry, I misspoke, that's type 1 diabetes. That's not type 2 diabetes, because type 2 diabetes we already know is associated with obesity. Type 1 diabetes, typically not. It's an autoimmune condition, but after several years of insulin treatment, their BMI exceeds that of healthy kids. And that is actually worsened with intensive insulin therapy. So the more intense I get with the insulin and trying to control the blood sugar, the worse this obesity or BMI issue gets. So in my mind, there is only one way. We need to look at the diet. And we already know that a low-carb diet has promising results in terms of weight, blood glucose control, metabolic health in people with type 2 diabetes. There is multiple, observational studies, RCTs, meta-analyses of studies that no matter which way you look at the problem, like type 2 diabetes does get better with a low-carb diet. The one thing I will say that there are studies and meta-analysis that don't find that that's the case, and I think that is typically linked to the sustainability over the long term. Like a lot of studies will find that Early on in the diet, it's very successful, and then sometimes later down it fades away. But in well-controlled trials that can control the diet over a long period of time in a rigorous way, a low-carb diet does improve diabetes control. There is also, data is always more sparse in adolescents, but we also have some studies that show adolescents with type 2 diabetes do better on a low-carb diet. Now, what about type 1 diabetes? If you look at the guidelines for nutrition for type 1 diabetes, before the invention of insulin, carbohydrate restrictions was the only treatment to help people with diabetes survive. After insulin came on the market, there has been for maybe until the 40s or so, people still remained on a fairly low carbohydrate diet. But then over time, those recommendations for carbohydrate restriction have been loosened gradually. Not so much because there was evidence that it was better, but because it kind of tasted, people were a little bit more comfortable with a less restrictive diets, and there wasn't any evidence to show that that was the wrong thing to do. Why was there no evidence that that was the wrong thing to do? I think I took a really close look at that literature and at that field. So it looks like there were studies comparing a looser carbohydrate diet with a formerly more restrictive diets. They didn't find a difference per se. They were not able to measure blood glucose levels. They were able to measure rates in ketoacidosis. They were not able to look at some of the more refined measures that we think are important right now. And then later on, there was this real run on a low-fat diet, and so a low-carb diet was just became completely neglected. So people just stopped doing research studies on nutrition for type 1 diabetes. Somewhere in here, in the 60s or so, the diabetes guidelines said, quote unquote, that because there is no reason to believe that a child with type 1 diabetes would have different nutritional requirement compared to a healthy child, as long as the diet is covered with insulin, and therefore we will take the recommendations from the general guideline, which we don't even agree with that, right? But if it were only that simple, because obviously, as we can tell with modern measurements, it's not that easy that you could just give insulin and control your blood sugar well. But because of that statement, I think we all jumped on the bandwagon of the low-fat diets, and that was propagated in the diabetes guidelines as well. And then more recently, I think more societies are coming around and talking about an individualized amount of carbohydrate or an individualized diet, but haven't yet seen for kids it to be recommended that they could follow a low carb diet. In spite of those guidelines, I think that low-carb diets are getting more popular in the diabetes, in people with type 1 diabetes. And so this is how I first found out about this approach, as I met some people in the type 1 GRIT Facebook community who are choosing this approach for themselves and or their children with type 1 diabetes. And in talking to them, I've learned that there is a lot of, satisfaction and relief because that diet improved their blood sugar control tremendously, but also frustration with the medical community in that they found that their physicians were not supporting them, either because they didn't know enough about the diet, they couldn't give them advice or recommendations, or worse, they were opposed and discouraged the approach, even threatened with child protective services and along those lines. So I kind of dug into this a bit more, and it's why is that? And I think, why can that be? I think it could be because the guidelines don't recommend this approach, right? It could be because there is really very little research on the field, and we actually don't know how safe it is. But we've got to be fair, there is no research in the other direction either, right? So no one's gone out and done the work that needs to be done to understand how safe and how helpful a low-carb diet is for kids with type 1 diabetes. Some of the hopes and concerns I've come across are actually surprisingly simple. Like, people hope that a low carb diet would decrease their ups and downs in blood sugar and therefore lower their risk of having a frank low blood sugar, which is dangerous. They think that it could benefit their cognitive performance if their blood sugar is more level. They think it could improve growth and development if their blood sugar is less up and down, and quality of life, reduce diabetes care burden, right? Like, if you don't have to stay up all night long to worry about a low, you might have a better time. On the other side, could a low-carb diet increase your risk for hypoglycemia? Because you're not eating enough carbs. What if you exercise and you haven't eaten carbs? Like, do you have fuels? Are you going to be low? Are you going to have enough stores in your liver to rescue you from like a low? Like, are you going to be able to, increase your blood sugar with glucagon? It's a common medication we use to increase blood glucose levels in kids with type 1 diabetes when they have a dangerous low. Is that going to work if you don't have any glycogen stores? Maybe. Could you have nutrient deficiencies, and is it actually going to impair your quality of life because you can't participate in the normal child activities like birthday parties? So I think the hopes and concerns are interesting because they're like in the same domains in opposite directions, right? Then, of course, like relating to insulin, could the lower insulin exposure improve your insulin sensitivity and metabolic health and lower your triglycerides and increase your HDL cholesterol, like we've heard? Versus, would the increased intake of saturated fats be adverse to those lipid panels and metabolic health? And then the last thing is, like, if you're eating really low carb and you're in ketosis, would the ketosis benefit your brain health? Or could the chronic ketosis even increase your risk for ketoacidosis, which is a feared complication of type 1 diabetes with insulin, where absolute insulin deficiency, you do not have insulin, so you uncontrollably break down fat and make ketones and become acidotic and could go in a coma and die, right? So those are kind of some of the, I think, pushbacks that we get, especially with type 1 diabetes for a low-carb diet. So as you can see, it's a tough field, right? Like, can you do it? Can you not do it? Should you not? And so I took a deep dive in the literature about it, and so there isn't, I'll summarize it in a second, but maybe I should skip that. Yeah, so I did like a literature review, 100 years of published studies, literature on nutrition and diabetes, and surprisingly, this is all I found in 100 years. So it's a relatively small list of studies that explicitly mention the amount of carbohydrate a person is eating in relation to their diabetes control. It took a long time to find those. I looked at 10,000s of papers to kind of extract those out. But here they are. And so I grouped them in moderate, moderate carbohydrate between 130 and 224. I didn't make this up, but this is kind of the classification. Low carb, 51 to 130 grams a day, and then very low carb, less than 50 grams a day. And you can't see it from here, but I'll tell you in my words. So the hemoglobin A1C in the moderate carb range, they're all between like 7, 8, and 9. So this is what we expected, and it reflects the data I've shown you. Then if we go and look at the low carb diets, same, like 7, there's some 6s, but not markedly improved. But then when we go to the very low carb field, I see hemoglobin A1Cs in the 5 range, right? So in the healthy range that a person without diabetes might have. What I'll point out about the very low carb diet is the number of people. Like, most of those studies are just case reports with 1 or 2 people in it. There is exactly 3 studies out there that have more than 1 person. One of them is like 11, 10, and then here's one with 316, and that happens to be a survey that we did. So it's not an RCT or anything. It's an observational study, but it's the largest study on the topic so far. And what we did in that study is we looked at 300 adults and parents of children with type 1 diabetes that eat a low-carb diet, and by their own report, they ate about 36 grams of carb a day for a duration of, on average, 2 years. And lo and behold, excellent glycemic control. Like, this is the distribution of their hemoglobin A1Cs. Really, the vast majority below the targets suggested by the ADA and the International Society for Pediatric Diabetes. Lipids, that was a question we had, right? So we can see here the total cholesterol and LDL a little bit higher than what's recommended optimally, but nothing crazy. But high HDL and high triglycerides, which are considered to be protective, right? And that's a pattern that we've seen over and over with low-carb diets, so consistent. Now, that pattern gets us a lot of pushback. People are really worried about that LDL cholesterol because kids have diabetes, they already have a cardiovascular risk factor, now you're going to increase their LDL. Is that terrible, right? The truth is, again, like, we couldn't do an RCT on that topic because it's going to take us controlled diet for 40, 50 years before we have a definite answer. But I'm going to look at the DCCT, which is a large study in thousands of kids and young adults with type 1 diabetes that looked at what might be the most important risk factors for cardiovascular events, and they found that hemoglobin A1C was by far the greatest risk factor, followed by elevated triglycerides, and only thirdly the LDL. So the way I read that data is that, and you can read it differently, but the way I read it is that maybe if I can improve 2 risk factors and only make the third important one worse, maybe that's worth my while to kind of keep trying for that approach. Ketoacidosis was one of the concerns, right? I already said, like, I think ketoacidosis happens when someone has absolutely no insulin and is breaking down fat and making ketones in an uncontrolled way. This is not what we see in nutritional ketosis, right? Like, we will never stop giving those kids insulin, so they will never have uncontrolled ketosis. And I think that just looking at the blood ketone levels with a diet is typically range from 0.5 to 3 millimolar, maybe 5 in extreme cases. Ketoacidosis almost universally above 5, more commonly above 10. Along those lines, DKA was not at all common in the survey that we performed. So I think I worry less about it. Hypoglycemia in 3 of the people that we surveyed, hypoglycemia was rare, and it compared favorably with registries of other people with diabetes. So they had lower rates of hypoglycemia compared to the standard population. Now, again, is it fair to make that comparison if I have a group of highly motivated people that change their diet but also potentially do other things that position them better? I don't know, but that's what I can say at this stage. Glucagon challenge. Like I just said, like some people worried that maybe if I give glucagon, I'm not going to be able to increase my blood sugar because I don't have enough glucose stored in my liver. So this is a study that someone else did in 10 adults with type 1 diabetes, where they put them on a high or low carb diet, and then they gave 2 doses of glucagon, a small dose and then a standard dose to increase their blood glucose levels. So the standard diet had a greater blood glucose response to the glucagon, right? And based on that, they went out and said, look, this is a dangerous diet because your blood sugar doesn't respond as well to glucagon because the only rate increased, like much less. The truth is, though, if you look at that increase in blood glucose from, sorry, I wish I had the milligrams per deciliter, but that glucose increase is more than sufficient to restore your blood glucose to normal. So it's not, yes, they responded less, but more than enough to be safe. So again, I feel like that's refuted a little bit. And then there is this is the most popular example against a low-carb diet for type 1 diabetes, where it's a published case series of 6 children that adopted a low-carb diet on their own, and then endocrinologists reported adverse outcomes such as low intake of calcium, magnesium, and poor weight gain and growth. However, this group of people also had other concerning features. So that, like, people stopped insulin. People said they were hungry, so they didn't eat enough. A person had intentional weight loss because of an eating disorder. So I think it's not fair to attribute all those effects. A, it's only 6 kids, and B, it's not fair to attribute that to the diet alone when there is so many other factors. Lastly, growth. Why do we worry about growth with a low-carb, AKA, or ketogenic diet? Like, there is some data from, the epilepsy field that have shown that kids on an extreme form of a ketogenic may not grow as well as other kids. Those kids were also on a number of other medications and didn't have good health. So I took the effort and got some growth data for those kids with type 1 diabetes on a low-carb diet, and it showed that indeed they didn't grow quite as fast as you might expect. So what I did here is I plotted from their physicians, so not self-reported, so this is pretty objective data, the height z-score, which means like how far away from average they are, and that should stay consistent across the childhood, and so that decreased from 0.4 at diagnosis to 0.2 after 2 years, of which like some of that was on the diet. So it's like, does that mean they're not growing as well, right? Here's data from 18,000 kids with type 1 diabetes from a national registry, and it plots their z-score over time since diagnosis. And as you can see, there is a slight drift down. So kids with type 1 diabetes maybe not grow as much, or slightly less than kids without type 1 diabetes, and our data was commensurate with that. So the kids on the low-carb diet grew just as you would expect for a child with type 1 diabetes. Psychosocial, there was some concerns about, disordered eating and birthday parties and whatnot. All I can say about that is that our group was very satisfied with the diet and didn't have any concerns, but it's something to obviously watch. Here is a big point of concern for me, like patient and provider interactions. I think the relationship of a patient with their medical team is really important in type 1 diabetes because they are at risk for complications and potentially life-threatening complications, and they need to be able to have a team to help them navigate those scenarios. 42% of the patients following this approach felt like disagreed or strongly disagreed or did not discuss their diet choices with their provider. And so I feel like that really undermines the possibility for a useful therapeutic relationship. Why I said not knowledgeable, they couldn't help, they were worried about conflicts. What's interesting is I don't think that the provider knew that, because almost universally, the providers said they were supportive or strongly supportive of the approach. So I think there's really a disconnect between patient and providers, and I think that's a risk. Now, how can we mitigate that? I think we can mitigate that by providing research, providing information, providing education, and maybe one day modifying the guidelines on how we approach this topic for kids with type 1 diabetes. Other studies I have coming up to help with that is I'm currently doing an RCT with young adults with type 1 diabetes, where they get their foods provided by us for 3 months, and the primary endpoint is glycemic control. They get either a low-carb diet with 5% carbs, 75% fat, 25 protein, or they get the standard diet with 50% carb, 30% fat, 20% protein. And they have continuous glucose monitors. We know about their blood sugars at all time. We get hemoglobin A1C, we get lipids, we get other markers of metabolic health. We do a glucagon challenge, again, to see if they have an appropriate response. And we do some MRIs too, because there is some thought that, as you've heard, that ketones may be a useful fuel for your brain in case of hypoglycemia. Hypoglycemia is a common concern for people with type 1 diabetes, during which they have low cognitive performance and can have seizures. So we do a study in the MRI where we drop the blood glucose level all the way down to 50 and have people perform a cognitive task and get images of the brain to see if a ketogenic diet could improve could help improve some of those concerns. Blood glucose control after before and after the low carb diet. So you could see this is the CGM tracing improved quite a bit, but statistical analysis have to wait. Another study that I'm going to start just this fall is a study in 50 children that will look at if a low carb diet could increase the period of diabetes remission. When a person is diagnosed with diabetes, they still can make some of their own insulin, and oftentimes they can make that for quite a few months. So the diabetes care is much easier in the first couple of weeks to months. But then universally so, the autoimmunity progresses and then they can no longer do that. There is some reason to believe that a ketogenic diet may modify the microbiome and may modify inflammation that could be protective against the beta cell autoimmunity and slow down the process. So we're going to test that hypothesis in a 9-month RCT where kids and their families will receive food and diet education, and we will look at specifically at beta cell function, glycemic control, microbiome, other factors, and so that's coming up in the fall. So I didn't leave myself a lot of time to talk about the carnivore diet, but thankfully, my previous speaker already spoke about the history of a carnivore diet, so I can skip right ahead in that. What I'll point out, I think the first account I found of a carnivore diet published is from 1797. A physician by the name of Rollo treated 2 people with diabetes with a carnivore diet of ripe meats and rancid fats, and found improvement in their diabetes control and survival beyond the period that was expected. And so over time, then a carnivore diet was modified and adapted by many diabetes care providers in that era, but then completely abandoned when insulin was invented in 1920. So people had used that diet before in the medical field. I'm going to skip over the Inuit stories that had been well described by my previous speaker, but will say that the Inuit experience of the Arctic explorer that was discussed inspired this explorer and one of his friends to stay in a hospital ward for a year and eat only meat and organ meat and animal products, and undergo rigorous physiologic experiments of their, kidney function and everything that could be measured at that time, and were both found to be in good health, surprisingly. So I think that was the first groundbreaking scientific account, experimental, right? As we said, observational and experimental. So this is the first known to me experimental approach or account of a carnivore diet. And then there is a really long void in the scientific literature. No one publishes anything. It's all over the social media, but it's not present in the scientific literature. So we partnered with Sean Baker and launched this huge survey study of a carnivore population. 2,000 participants answered our survey questions, and they had been on the diet for on average a year, but up to 28 years in one participants. Included males and females, interestingly also pregnant and breastfeeding women, mostly in the US, Australia, and Europe, from mixed backgrounds, but mostly of high educational status. Why did people do this? People said they did this because predominantly of their health. 93% of people said, I'm only eating meat because I want to become healthier. And that's astounding if you think about, coming from a physician perspective, you're like, oh, that couldn't be healthy, right? But the main reason was improvement in health. A few said it was a food preference, some out of curiosity, ethical reasons, or other, but the vast majority health. And the health reasons included body weight composition, athletic performance, focus and energy, and then a large proportion said to improve their allergies, skin or autoimmune conditions, right? And I think the theory behind that is, yes, it's a carnivore diet is an extreme form of a low-carb diet, but it also cuts out a lot of phytochemicals and potential allergens and may have, additional action there. So what did those people report to eat? So we confronted people with a scale of, what do you eat with each meal, every day, weekly, monthly, less than monthly, never. And I don't expect you to read this, but it's color-coded, things that they, eat that most people do and most people don't do. So up here is the meats, dairy, eggs, milk, nuts, fruits, vegetables, sugars, processed foods, those kind of things. And you could see, it's very clear, right? Red meat is super common. More than 85% of people eat red meat daily or with every meal. Fruits, vegetables, less than 10%, so less than monthly. 90% of people say they eat red meat, they eat fruits, vegetables less than once a month, which is essentially never, right? So almost everyone doesn't eat fruits or vegetables. And then also, a third of people didn't take any vitamin supplements, because when we went in, there was they don't have scurvy because they take vitamin C, right? But no, people don't take vitamin. A large proportion of them do not. And so we did specifically analyze to see if there's differences in symptoms of vitamin deficiency or health or other aspects of the survey that would distinguish people who do or do not take vitamins or people who do or do not take vegetables occasionally, but we cannot find a difference. So the people who did not take any vitamins, even though they were a minority, they fared just as well as everyone else. So it doesn't seem to be necessary against public belief that you take a vitamin. There was very few adverse symptoms, 3 to 5% reported some sort of GI issue, discomfort, like bloating or diarrhea or constipation. Some people had some muscle aches and pains and a rash, some people reported rashes. That was the majority. You look at the perceived health improvements. So this is this graph I made. This is percent participants reporting a change. Sorry, the legend seems to. So this is improvement, same or worsening, and those are the conditions, right? So 69, 95, 91, 85, large proportion of people reported improvements in their either chronic disease, overall health, hunger and food cravings, mental clarity, memory, focus, sleep, strength, endurance, energy levels. Here about between 5 and 30% said they didn't see any changes in either of those domains, and only 1 to 3% reported some worsening, maybe in sleep here, hunger. So it looks vastly that positive experiences with that diet, right? Then when you look at the chronic conditions, so we asked a bunch of chronic conditions: obesity, underweight, lipid abnormalities, hypertension, cardiovascular, autoimmune, musculoskeletal. As you can see, this is here: resolved, improved, unchanged, worsened, or new. So no one had a new condition. Very few people had worsening, and the worsening was in lipid abnormalities, which we already kind of heard about. By the way, that tells me that people are being honest about the report, right? I don't just get glowing positives. I get some people honestly report if things got worse, at least some of them, which is speaks to the quality of the data in a way. Underweight, seems like some people had some underweight issues and eye problems. No, that's unchanged, never mind. Unchanged, it doesn't seem to make much difference for eye problems for a lot of people. And then a huge proportion of people reported improvement or resolution of their chronic health condition. Now, sit tight, this is self-report, right? We didn't measure this. This is what people said and perceived. So we've got to take the word for it. So we did assess some objective measures. We got weights and BMIs and some lab levels, some commonly checked lab levels, and we showed changes between, again, the legend is missing, on the diet and before the diet. So body mass index improved from 27 to 24, cholesterol total increased from 209 to 256, LDL from 126 to 175, HDL 58 to 68, triglycerides 83 to 68, A1C improved, but the number looks the same, but there was still an improvement, and the CRP improved as well. Other labs were not affected. So liver and kidney function seemed to be the same. So what can we say? Like it seems like this is, this is just a survey. Like this is observational and with all the caveats and that we've mentioned. But this is a large group of people, and I think it definitely raises the possibility that, or mandates the possibility that there needs to be more research on the topic, and that we have to look at this more closely. In all domains, on a population level, observational studies, maybe even short-term RCTs to test specific hypotheses. And I'm excited to set out on that. That's all I had to say.
Hi, my name is Roxana. I have a question. I get a lot of pushback in groups from people of type 1 children. They'd say that type 1 children have eating disorders anyway. And with carb-restricted eating, does the data show that there's more eating disorders, or is it better, or is it same?
All right. Well, first of all, there is no data, which is probably going to be my universal answer to all questions. But restrictive diets have been linked to increase in eating disorders, not specific to carbs, but just in general to restrictive diets. Diabetes, I think, is linked with increased eating disorder because you have so much focus on diet and food and how you handle it, right? It's a daily concern to think about the food. What do I eat? When do I eat? How much insulin do I take for it? How is my exercise going to affect that? Am I going to high or am I going to low? Should I not eat because I'm too high, or should I eat more because I'm low? So there's all this preoccupation with food that's, to me, very akin to a restrictive diet. And I wonder if that is the common mechanism for the, heightened eating disorder. And with a low-carb diet, yes, are you going to superimpose a restrictive diet, and are you going to make that worse? Or maybe, are you going to take away some of those concerns, right? Are you going to be able to stabilize their blood sugar a bit more? Are you going to allow them to not think about insulin 20 minutes before they eat? Because this is also the truth. Yes, you still need to take insulin for meals when you do low carb, but you don't have to wait 20 minutes because the glucose rise we get from proteins is like over the course of 2 and 3 hours and matches perfectly with the insulin. Am I going to be able to alleviate some of those concerns and maybe make their situation better in that regard? So I think that invites for a systematic evaluation. I certainly, when I have, I'm predominantly a researcher, but I also have patients who follow a low-carb diet. I always work closely with nutritionists and psychologists to kind of see how kids feel and, just assess and ask for that in the clinical, but it should also be done in the research setting, I think.
For the management of type 1 diabetes, what's your input for the use of metformin as an adjuvant to reduce insulin requirement, reduce hyperglucagonemia, and to help with postprandial glucose rise?
I think it's more commonly used in adults. In kids, it's still rare. But I do use that in kids who have unusually high insulin requirements and with some relief. I haven't used it in kids who are eating a healthy diet and are physically active and have a moderate insulin requirement. I haven't, but it's maybe worth a thought. But definitely in kids with higher than usual requirements, we've added that.
Thank you.
Mm-hmm.
Andrew Kudnick and a couple other type 1 diabetics who are low carb and athletes, like high intensity athletes, they'll report that they're shooting twice as much. Like if they don't shoot insulin before they exercise, they get a super hyperglycemic response. And if they don't take insulin first, they use twice as much insulin to get it under control. Do you see that in kids also?
With a low-carb diet? Yeah, I think with or without that, what's interesting about exercise is that usually if kids are on a high-carb diet and they exercise, they go very low and they have to eat a lot of extra sugar to keep up their blood sugar. I don't see that so much in a low-carb diet. Like they tend to be a lot more steady, right? Like they seem anecdotally less at risk for hypoglycemia. What I find, though, is
well, they're seeing hyperglycemia.
With a hyperglycemia, yes, it's like thought related to the adrenaline spike, and I've seen people bolus for that, give insulin for that. I have not myself, but I know some other low-carb providers use beta blockers to mitigate that adrenaline spike and report good success with that, but I haven't personally used that.
All right, thank you. Mm-hmm.
Hi, doctor. Thank you for your work. I do similar work with metabolic health in adolescents, and I add in protein. So how do you handle, the appropriate amount of macros in a type 1 diabetic who may have impaired renal function?
For protein?
Mm-hmm. Sometimes I find that instead of like going from a restrictive mindset and giving them autonomy, that we add in the positive, and so adding in protein, and teens aren't getting enough protein, that seems to be a really helpful mindset.
Yeah. I haven't had to be too restrictive about protein in some of my patients, because like renal disease to the degree where you have to just restrict is rare in adolescents. So I can't say that I've had to do that much. I also know that there's some controversy on is how important it really is. Like that was another thing that came up when I reviewed the literature. There was quite some thoughts in different directions if it's necessary, but I don't have first-hand experience.
Okay, cool. And then the other thing is, I've always had such a hard time getting pediatric endocrinologists to order fasting insulin. Okay, I'm sorry. Okay.
Dr. Belinda, for your patients with type 1 diabetes who are able to adhere to a very strict or carnivore diet, how low are you able to get their insulin dosage?
So I had, like in the survey, the average insulin dose for the kids was about 0.3 units per kilo per day, which is maybe a third or half of that of an average child. Like, depending on the age, yeah.
Thank you.
Mm-hmm.
Hi. In your study, when you looked at improvements of various organ system disorders, did you see any improvements or worsening with the carnivore diet in reproductive or gynecologic disorders, or was that even a question?
I don't think that was a question. It's a sad omission.
A few years back, Professor Noakes was talking about a glucagon antagonist or blocker to help with this hyperglycemia in type 1s. Has anything panned out with that, or are there any research going on to block that effect? So the reason I ask is some of the carnivores keep their insulin super low, like Sean Baker, but his A1C is high and his sugars may run high because they think you're not getting that suppression effect of the insulin.
Yeah. No, I don't know any updates on that.
All right, thank you.
I just read in Pediatric News about the Today study on type 2 diabetes in adolescents, and there was a pediatric endocrinologist from, I think, Columbia talking about how like a hemoglobin A1C of like even 6.2%, and these kids having type 2 diabetes, insulin resistance, for like 13 years as they're entering young adulthood, are having really impaired kidney function and cardiovascular disease and the chronic issues. I'm so glad you're beating the drum of the nutritional research. There was no mention at all of any nutritional interventions. It was all medications including the GLP-1s. Are you aware of that study? I'm sure you are, but also, what are your thoughts of how to integrate your work with your pediatric endocrine colleagues so we can get that out?
Yeah, so as I said, I think it's like the blood glucose is a homeostatic system, and you have to control the ins and the outs, and the whole world is working on the outs right now, and so I think diet would be a perfect adjunct to some of those studies. How do I interface with my colleagues? I do that research at a quite large institution. We have some partnership with the Joslin, trying to engage young people to join my my team. So I think, but it's hard, right? Like there isn't a lot of funding in nutrition research, and it's a long road. Like it has limitations. So I think all I could do is spread the word, and work together. I think that, and a really interesting study that I think would be fascinating with the technology we have with a bionic pancreas, like that in combination with a low-carb diet could be huge.
Cool, thanks.
What about excessive fat consumption in a meal and basal insulin requirement? Does too much fat in a meal induce a transitory insulin resistance?
It's interesting, right? Because fat, when you eat fat in a meal, like a high carb, high fat meal, you definitely need to cover that with more insulin. But I don't think that if you just eat the fat without the carbs, that is true in the same way, which is, haven't yet fully clarified why that is. But maybe it has to do with the absorption of the carbs and the fat together and like how they interact.
Maybe an implication of the Randall cycle, like a competition between the fat and the carbs in the...
Right. And you know, obviously if you eat the carbs and the fat, you have a higher insulin state and higher insulin requirement at the same time. So I wonder if then, because you ate that fat, and maybe if you're insulin resistant, doesn't allow your carbs to be absorbed as effectively, but it doesn't seem to be an issue for the people who do the low-carb diet.
Hello. What instructions do you give to patients and parents when someone is having a hypo? Because traditionally we'd say have a glass of orange juice, but that isn't going to work, right? That's going to put them high for
so they still, I still think that the treatment for a low is a rapid acting carb, right? Like you've got to correct it and you've got to correct it quickly. What I think is different is the amount, because it's a much lower insulin state, so the amount of carbohydrate you need to correct that low is going to be less. So in the study I'm doing right now, like the standard recommendation for kids is that they take between 10 and 15 grams of glucose to correct a low. In the low-carb study I'm doing, we find it's like often 2 or 4 grams is sufficient. So, but it's the same principle. Like you have a low, you've got to treat that with something that corrects it quickly, just less.
Thank you.
Mm-hmm.